Hello and welcome to another uh, live stream of Dr. Barbara Miller's NCLEX review or the State Board of Nursing review. The topic of today is on diabetes, which is so important for you to journal your notes because these are commonly asked on the State Board of Nursing, whether it comes in case studies or multiple choice or select all that applies, but you will often see diabetes on your NCLEX. So what is diabetes mellitus? This is a disorder in which the amount of glucose in the blood elevated. What happened in diabetes mellitus? The food that we eat is broken down into glucose and absorbed in our blood. Simple carbs are broken down the fastest, followed by complex carbs, and then protein and fats. Once the glucose in the blood, the pancreas releases insulin to move the glucose out of the blood and into the cells. This is so important for you to remember. From the cells, the glucose is either used by the body immediately or stored in the liver and the muscles as glycogen, or in the body as fat. If the liver, muscles, glucagon stores are full. Number 5, in diabetes, the pancreas either doesn't release enough insulin or doesn't release any at all. The cells do not respond to insulin. And 6, all situations leads to high levels of glucose, which is also known as hyperglycemia. So you do have types of diabetes. You have prediabetes, you have type 1, type 2, you have gestational diabetes. So let's start with prediabetes. In that phase, the blood glucose levels too high to be considered normal, but not high enough to be labeled as diabetes. So they keep monitoring those patients. Fasting blood glucose levels are 100 to 125 milligrams per deciliter. Decreased body weight by 5 to 10% can usually return the blood glucose levels back to its normal and decrease the risk of diabetes in the future. So type 1 diabetes, okay? And what is that? In type 1 diabetes, the pancreas produces little to no insulin because the insulin producing cells have been destroyed, usually diagnosed at a young age. So remember, type 1, normally called juvenile diabetes. It happens suddenly. Patient must take insulin each day for life. Why? What are the causes? It has genetic components. It could be autoimmune, like a virus. What are some clinical manifestations of type 1 diabetes? Patient usually young and thin in body. They're experiencing the 3 Ps. What are the 3 Ps? You have polyuria, polydipsia, and polyphagia. So polyuria, the blood levels increase above 160 to 180, or the blood glucose levels, milligrams per deciliter. Glucose spills into the urine. The kidneys will excrete um, water to dilute the glucose. Polydipsia, excessive urination or excessive thirst, rather. Okay, so the patient will urinate a whole lot. And polyphagia is um, hunger. Okay, hunger. Patient eats and eats and eats. So let's go back. 3 P's that you must know when you're referring to type 1 diabetes: polyuria, polydipsia, and polyphagia. What are other clinical manifestations of type 1 diabetes? Patient's breath smells of acetone due to DKA. What is DKA? Diabetic ketoacidosis, where the glucose could go higher, which places the patient in a life-threatening situation. Then you have blur vision, drowsiness, the patient becomes nauseated, decreased endurance during exercise. Okay, wound heals slowly. If the patient has a wound, um, patient has rashes, and also at risk for yeast infection. Then you have type 2 diabetes, also known as insulin resistance. The pancreas produces insulin, however, the cells do not respond to it at all, known as insulin resistance. The glucose can't get into the cells in type 2 diabetes. The pancreas continues to produce insulin, which leads to hyperinsulinemia. And forgive me for batching that. Hyperinsulinemia leads to metabolic syndrome. Okay. What are the causes of type 2 diabetes? Obesity is a major factor in type 2 diabetes, or sedentary lifestyle, sitting, watching TV all day, and not doing much. Poor diet also is a factor. Lots of refined carbohydrates. Stress also is a major contributor to type 2 diabetes. Plus, type 2 diabetes also has genetic components. Patients usually overweight in their adult phase of life. So the metabolic syndrome for type 2 diabetes: increase in blood pressure, include increase in blood glucose, okay, decrease in the good cholesterol, uh, the, the, the HDL, and excess fat around the waist. So what are some clinical manifestations of type 2 diabetes? This may take years before diagnosed. Its symptom is subtle at first: increased urination, increased thirst, patient is fatigued, patients start having blur visions, they become dehydrated, slow wound healing, they would often get rashes, yeast infection, and glycosuria. The other type of diabetes that patient normally gets is that of gestational diabetes. And what is gestational diabetes? It occurs during pregnancy around the 24th to 28 weeks of gestation. This type of diabetes is similar to type 2 diabetes. The cells not receptive to insulin may need to take insulin during pregnancy. You must monitor their blood glucose levels and their diet throughout the pregnancy. It goes away after pregnancy. Remember, patient with uh, gestational diabetes, they will have macrosomic babies, meaning large babies for gestational age. The average baby weights maybe around 8.5 pounds. Okay, they're at risk for stillborn. Baby dies in utero, and those babies also at risk after birth. They will have problems with stabilizing their glucose, hypoglycemia, low glucose levels. So they would normally treat those babies with glucagon or glycagon. So what are the treatments for diabetes? Each diet will vary per patient as the individual glucose respond differently to different foods. Begins with diabetes plate, non-starchy vegetables, broccoli, tomatoes, lettuce, etc. Carbohydrate foods, bread, pasta, lean beef, chicken, eggs, and beans, etc. It is so important to engage the patient in an exercise plan. If the patient is 100 milligrams glucose is less than 100 milligrams per deciliter, you want to have them eat small carbs before exercise. Why? Because exercise could drop the glucose levels to a dangerous level. Patient could go into hypoglycemic, okay, while exercising. You want to have simple carb on hand. If the glucose is greater than 300 milligrams per deciliter, you want to wait until the glucose decreases before exercising. If exercise for extended period of time, you want to monitor the glucose during exercise. It is so important to monitor the glucose during exercise. Okay? Um, Additional food may be needed as intensify to the duration rises. What are some medications that they will give? Remember, they could give oral hypoglycemic agent for type 2. You need to know and go over these medications because they can show it up in different form, whether it's a case study, matching, select all that applies, okay? They can show up. So let's go over the medication that they administer for type 2 diabetes. The first one is metformin, okay? So metformin or biguandes, it decreases liver stores of glycogen. It increases the body sensitivity to insulin. What are the side effects? Abdominal pain, bloating, and diarrhea. The next set of medication, oral glycemic, glyburide, glipizide, glimepiride. These helps the body secretes insulin. You are to avoid alcohol, side effects are hypoglycemia and weight gain. The next set of medications are ripaglinide. This helps the body to secrete insulin, fasting acting. What are the side effects? The side effects are hypoglycemia and weight gain. Just remember, most of these hypoglycemic agents that do cause weight gain. Another set, Avandia or Actos, makes tissue more sensitive to insulin. Um, to insulin, it decreases the glucose production in the liver. The side effects, it increases risk for heart failure, bladder cancer, bone fracture. It also increases weight. And last but not least, the precoce or the glycet, it blocks the breakdown of starchy foods you want to take with the first bite of each meal. Side effects, it causes buildup of gas, diarrhea, and stomach ache. You want to instruct your patient to watch for hypoglycemia with beta blockers, aspirin, the MAO inhibitors, Bactrim, and alcohol. You want to also instruct your patient to watch for hyperglycemia with thiazide diuretics, glucocorticoids, estrogen therapy. Type 1 and sometimes type 2 will need insulin. Okay? Why type 2 would need insulin if the antihyperglycemic agent is not working effectively? Yes, they will resort to insulin, more so if the patient has transplantation, such as a renal transplantation. They do not want the kidney to malfunction, okay, with high glucose levels. So what they will do, place that patient on insulin. So insulin, the important for you to remember that it's 4 types of insulin, and you're to know the onset, the peak, and the duration of each insulin. So let's start with rapid acting insulin. This type of insulin you want to take with meals. Okay? What are some rapid acting insulin? Aspart, Lispro, Glulicine. The onset of rapid acting is 15 minutes. It peaks in the blood an hour, and the duration is 3 hours. Remember, they have this Ralph rapidly ate lots of grapes, 15 red, 1 green, and 3 seedless, to remember rapid acting insulin. Let's go to short acting, also known as regular insulin. Regular insulin is given to patient who is in diabetic ketoacidosis via IV. Don't forget that, because insulin normally gives subcutaneously. So what is the onset of short acting or regular insulin? The onset is 30 minutes. The peak is 2 hours. The duration is 8 hours. You want to take 30 to 40 minutes before eating. Then you have your intermediate insulin. And what is that? Your intermediate, also known as your NPH. The NPH, the onset of the NPH is 2 hours. The peak, 8 hours. The duration, 16 hours. It covers insulin need for half a day. To remember, in the night, Paul had 2 8-ounces glasses of water and pee 16 times. And last but not least is the long-acting insulin. What are some long-acting insulin? Detamir, Lantus, Glargine. What's the onset of long-acting? 2 hours. Long-acting has no peak, and the duration is 24 hours. You do not mix long-acting insulin. Long-acting insulin covers the insulin need for the entire day. Two things that you must be mindful of when you are journaling your notes on diabetes, because they will often show up on your state board of nursing: the Smoothy effect and the dawn phenomenon. So what are they? The Smoothy effect, the patient will have a drop in the blood glucose in the middle of the night, maybe around 2, 3 o'clock, causes rebound hyperglycemia in the AM. So you want to treat with bedtime snacks of carbs, and you want to lower the insulin. That's the solution for the smooth effect. Then you have the dawn phenomenon. It's natural increase in the blood glucose right before waking, maybe around 5, 6 a.m. There is no insulin to deal with the blood glucose, leading to hyperglycemia. So you want to treat with bedtime, you want to increase the insulin for the dawn phenomena. And for the Smoothy effect, you want to lower the insulin and give more carbs. So what are the complications of diabetes? Diabetes could cause havoc, okay? Major life-threatening situations. For hypoglycemia, when the glucose goes below 60 milligrams per deciliter, the normal glucose is 70 to 110. So what are the clinical manifestations or the side effects? Sweating, clammy, the skin becomes clammy. Patient is confused, they're lightheaded, they have double vision, they have tremors. So how do you treat hypoglycemia? Simple carbs, fruit juice, and apple juice is great. Honey, you could dip like a teaspoon or a full spoon of honey. Hard candy, glucose tablets or gels, IV D50 if the patient is unconscious. You do have other complications of diabetes, such as atherosclerosis And what is that? Plaque formation in the artery. Atherosclerosis, patient could start having angina. What is angina? Chest pain, heart failure, and also stroke. They are also at risk for diabetic retinopathy, detachment of the retina. They also at risk for neuropathy, numbness and tingling in the extremities, high blood pressures, chronic kidney disease, fatty liver disease, yeast infection, ulcers, infection of the feet. It is paramount for you to instruct your patient. After showers, they need to dry between the toes because moisture brings bacteria, and patient could end up with infection where it becomes gangrene and need to be amputated. Let's talk about diabetic ketoacidosis. It mostly affects type 1 diabetes. Patient glucose will exceed 300 milligrams per deciliter. No insulin. Body burns fat for energy, produces ketones, byproduct, excess acid in the body, acid base imbalance. Remember, they will have metabolic acidosis, diabetic ketoacidosis. The kidney attempts to reabsorb the glucose, but there is too much. The glucose then leaks into the urine, osmotic diuresis, where the patient will have polyuria and excretion of electrolyte, such as their sodium, their potassium, and their chloride. Then now they become dehydrated. Okay? Patient, usually young, will lead to coma and death if not treated. So, what's the cause of type 1 diabetes? Undiagnosed, not taking appropriate insulin, not eating, or experiencing sepsis or extreme stress. So, what are the signs of DKA? Polyuria, polydipsia, dehydration, weight loss, fatigue, fruity smell breath, also known as ketones, tachycardia. They have a drop in their blood pressures. They have something called Kussmaul breathing. Okay, it occurs to correct the blood acidity. They will have abdominal pain in kids. Blood pH is going to be less than 7.35, and their bicarb is going to be less than 15. Remember, the normal bicarb is 22 to 26 milliequivalent per liter. So what's the intervention for DKA? The goal is to increase hydration, decrease blood glucose, correct acid base imbalance. So you want to treat hydration first, okay? 0.9 normal saline to progress to 0.45 normal saline, D5W added to 0.45 normal saline. Once the blood glucose is between 250 and 300 milligrams per deciliter, then they're going to treat the blood glucose. IV regular insulin. Make sure the potassium is normal. greater than 3.3. You want to monitor blood hourly, blood glucose rather hourly. You want to monitor potassium levels. You want to add potassium to the IV if needed and monitor for cerebral edema. One last thing that you will see in type 2 diabetes is hyperosmolar hyperglycemic state, HHS. H is in Harry, H is in Harry, S is in Sam. The blood glucose extremely high, exceeding 600 milligrams per deciliter, passing large amount of urine, patient becomes severe dehydrated, blood abnormally concentrated, hyperosmolar. It differs from DKA in that patient has some insulin. So there is no need, no breakdown of fats, no ketosis or metabolic acidosis. Kidney attempts to reabsorb glucose, but there is too much. Glucose leaks into the urine, osmotic diuresis. Patient will have polyuria and excretion of electrolytes such as their sodium, their potassium, their chloride, and then they become dehydrated. What are the causes of type 2 diabetes with illness or infection or taking corticosteroids or diuretics, usually older adults? So what are the clinical manifestations of hyperosmolar hyperglycemic state, which occurs in type 2? Mental changes. Their mental status changes, okay? They will become confused, drowsy, until they goes into coma, hyperglycemia. Their blood glucose is greater than 600 milligrams per deciliter. They have polyuria, polydipsia, dehydration, fever, fatigue. So what's your intervention? The goal is to increase hydration and decrease their blood glucose. Hydrating the patient will help solve the blood glucose problem. So you want to focus on that first. You want to treat hydration. You want to give isotonic fluids such as 0.9 normal saline. Then you progress to 0.45 normal saline. D5W added to 0.45 normal saline once the blood glucose is now between 250 and 300 milligrams per deciliter. So don't forget, hyperosmolar, hyperglycemic state, you want to treat IV regular insulin, yes. Make sure the potassium is normal. You want to monitor the blood glucose hourly. You want to monitor their potassium, because remember, an increase in the potassium affects the T wave on the EKG, or a decrease in the potassium, you will see a prominent U wave. You want to monitor for cerebral edema. Any questions? Any questions? No questions at all? Okay, so it is more to come. Tomorrow, I will go over another important topic, such as diabetes insipidus, has nothing to do with diabetes mellitus, and also syndrome of antidiuretic hormone. Okay, syndrome of inappropriate antidiuretic hormone that has to do with the ADH. Okay, so thank you for watching this live stream. Hope it's beneficial in your preparation for your State Board of Nursing examination. Thank you so much, and I will see you tomorrow.